So I think acute respiratory disease Sarah has already discussed, no? So that's actually I should bear in because a huge topic in here taught in 45 minutes, 1 hour. Again, another task given to me. Who is this person? I was showing a answer. Sarah has asked me only because of him I am here. Okay, so my thanks to Sir and he asked me to cover the chronic respiratory disease in 45 minutes to 1 hour. So I thought it's a.
Students are lucky to get you in this batch.
I initially thought it's a mission impossible. But he told me that the Mugambia students are very bright students. You need to just take them to the key points. Then I thought I will finish it in 45 minutes or now. No. So you are smart students, I know you are actually answering very well. So with that, I will ask, can you mention one chronic respiratory disease? So you are getting an ice cream. Any other chronic respiratory disease? Interstitial lung disease. Chocolates. Any other chronic respiratory disease? Asthma. You are getting a biryani. One more. Suppurated lung disease together we already mentioned. So we already said asthma. We have COPD. Tuberculosis. Those who said tuberculosis will get a balloon also. So this is actually what I am going to discuss about asthma, COPD, suppurated lung disease, carcinoma lung and tuberculosis. I will not be going with the details of all the disease, but I will just give an outline. Okay. So this also there is some difference, but it is better to call any respiratory disease or symptoms less than 2 weeks as acute, more than 2 months or even 3 months, more than 2 months as chronic respiratory disease. Between 2 weeks and 2 months you call it as a subacute or an acute chronic disease, acute on chronic disease. Okay. So importance is any patient giving complaints less than 2 weeks, you call it as a acute respiratory disease where the diagnosis of SARS, pneumonia, pulmonary embolism, pneumothorax, blah 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 will come. Any patient with more than 2 months of cough, our diagnosis of COPD, asthma, chronic bronchitis, blah 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 will come. Okay, so that is it. Now we will, these are the common respiratory disease, chronic respiratory disease, asthma, COPD, TB, suppurated lung disease. In this umbrella will come bronchitis, emphysema and lung abscess, interstitial lung disease and carcinoma lung. These are the common chronic diseases I see in the OPD and in my ward. Okay, the commonest chronic respiratory disease is asthma. But an asthma patient coming with a casualty with increase in breathlessness, what is it? It's an acute exacerbation of asthma. So certain disease has both acute phase and the disease per se is a chronic one, but when he comes with an exacerbation, you call it an acute exacerbation asthma. What is the importance? Then the management is different. An asthma patient coming to the casualty with increased breathlessness, you just tell, it's a chronic disease, go, you continue the treatment. No, you have to change the entire treatment. So that is the importance of knowing that. Okay, so we will take asthma. Happy? Asthma? Everybody know asthma. I think now no need to teach. And what is this queue? Kerala. When I came from Trivandrum to here, I saw. At least the shops are not open. Still there are few people standing to the queue. This is the beverages corporation's queue where you liquor being served. Very pleasant queue. Even old man, foreigner, everybody is in the very quiet queue. What is this queue? Everybody is to buy a ration. Ration shop, you are using this type of queue. This is unfortunately the queue in Hyderabad for swallowing a poor fish for the search of curing asthma. This is still going on. In Hyderabad, there are few centers They are making a lot of money and putting some fish into the mouth saying that it will cure asthma. Why I am showing these figures are asthma is actually poorly managed in India because we are managing with fish therapy. See, a fish is being pushed. Huh? There are some powders claiming that cure asthma. There are tablets being given, injections being given. These are not the treatment of asthma. The treatment is actually inhaled. So only, unfortunately, only 11% of our Indian populations are getting the correct treatment. 89% of the people are getting wrong treatment. So the point you have to learn is asthma, the correct treatment is inhaled medication. Okay, inhaled medication. From that, I will start my topic. As sir said, nearly 9% of the population, Indian population, global population is asthmatic. The difference is children, our 14% of our children are asthmatic. And nearly 7 to 12% of our adult population. It's not a small number. Among 100 children, 10 to 14 are asthmatic. It's a huge number. Okay. Huge number. So, what is a typical case of asthma? You may not get a case of asthma for exam, but for postgraduate, now I am insisting on giving COPD and asthma because they are the common respiratory disease. Usually we give fibrocavitary, we keep cooking a finding, cavernous breathing and giving mark. I think it's not it's a wrong thing. You are not going to see a lot of fibrocavitary in the later life. When you start practicing fibrocavitary, will be less because we are managing TB very well now. So what is important to know the management of asthma and COPD? No? So a typical asthma patient is of any age group. We look into the prevalence of asthma in children 14% and adult 10%. So any age can be affected. There are two factors which causing asthma. One is allergy. Number two is genetic predominance. So atopy and genetic are the two important causes of asthma. I would say there are only two causes. If both your parents, mother and father are asthmatic, 25% chance you are likely to get asthma. So that's the prevalence. Okay. And the patient comes as breathlessness. What is the type of breathlessness the asthma patient have? That's called episodic breathlessness. COPD patients will get what? Exertional breathlessness. They will be happy when sitting like this. When they start exerting, and you will grade like MMRC 1, 2, 3 based on the patient's breathlessness. But asthma patients will tell you that, sir, I am okay today morning. When I had some dust exposure, suddenly I got wheezy. That's called episodic breathlessness. Where you commonly see episodes? TV serial, na? Episode number 1225. The same story for 800 also. Why it's called episode? Why it's called episode? TV serials are episodes. Because you see that episode, a particular channel, a particular time, you have to do your, that's called a trigger factor. So asthma is episodic. Why? Because the breathlessness is precipitated by a trigger factor. What are the trigger factors? Allergy, infections, some certain drugs. Can you tell few drugs which can cause bronchospasm? So I was telling in the morning. Beta blockers, non-steroidal anti-inflammatory drugs. I had a patient who was very well controlled with my treatment. I was working in Trivandrum. So very well controlled. He came to the OPD and he was very okay. I used to continue. After 20 minutes, I saw the patient, the casualty. What happened? He had a headache while standing for a bus in this thing. He saw a medical shop opposite. He went there. He was given a NSID. He took it with a cup of water or a lime juice. After 20 minutes, he was in the casualty. So there are drugs which can cause bronchospasm. And when you examine clinically, the finding is bilateral. So this is a typical case. So any patient, any age group coming with episodic breathlessness, on aspiration bilateral wronging, with a history of allergy. The first possibility, sometimes COPD will confuse with you, but the first diagnosis is asthma. Okay, asthma. Now, this is the normal airway. You have the bronchus, the normal lumen and normal bronchus. And when there is an allergen, what will happen? The happening, this I think you have to understand. What is happening in the asthmatic airway is an eosinophilic inflammation is developing. So asthma patients, even though they are complaining of breathlessness, what we doctors, medical students should understand that airway inflammation, eosinophilic inflammation is the main problem which is happening, and subsequently your airway become narrowed. It become narrowed. See, the lumen is narrowed. The entire part is inflamed, and there is bronchoconstriction also. Spasm, airway inflammation, and mucus protection. So asthma is a chronic inflammatory disease. Eosinophilic inflammation is the pathology. The three components are bronchospasm, mucus protection. Over. This is much only you need to understand about asthma. So these are the basic points of asthma. Now this is again the same thing. This is a normal bronchus, that's the inflamed bronchus. Okay, back to the So again back to my points. Asthma is a chronic inflammatory disease. Never say asthma is a bronchospasm disease. It's actually a secondary feature. And the three components are airway inflammation, bronchospasm, and mucus protection. So one word you can say asthma is an airway inflammation, subsequently is bronchospasm. So the importance is, with this we can say what is the diagnostic test and what is the treatment. Okay, to make a diagnosis, either you document bronchospasm in that patient with your auscultation bronchi, or doing a test demonstrating bronchospasm, or if possible you can demonstrate airway inflammation also. But demonstrating airway inflammation is a too hectic procedure. So indirectly what we are doing is, we are auscultating and we are doing a test that will come later on. Okay. So the test for diagnosis asthma is called spirometry, otherwise we call pulmonary function test. Pulmonary function test is a group of tests. And among that pulmonary function test, one test which we use for diagnosis asthma is called spirometry. Spirometry. Okay. So this is the machine. This is one of the machine. And what you need to understand, even a child can do this test. Or he can, any age group above 5 years who can do this. It's a simple test. What you have to do is, you have to just blow into the machine will pick out the airflow and will tell you that there is an airway obstruction. Okay. And one point I want to say is, spirometry is a diagnostic test. Okay. It's a simple test. If you do spirometry, what will you demonstrate? You will demonstrate an airway obstruction. But that will be there in COPD also. But what is the extra test you do for asthma? That I know. You nebulize the patient with a bronchodilator, preferably salbutamol, and repeat the times once again. After 30 minutes or 20 minutes, do once again. And the previous bronchial obstruction or bronchospasm will be relieved. How much? 12% and 200 ml is the correct. But roughly it is 12 to 15%. Okay. The exact is 12% plus 200 ml. That is the correct bronchodilator. So we do a spirometry demonstrating bronchospasm obstruction with a reversibility is the gold standard test. Is the test which we are doing. But airway inflammation is also possible in this. Now coming to the management of asthma. We said airway inflammation plus bronchospasm is asthma. Okay. Patient is bothered about his bronchospasm, but we doctors being intelligent is more thought of actually the airway inflammation. So there is only one drug which can control the airway inflammation, that is corticosteroid. But we again know corticosteroid, if you take as tablet, has number of side effects. So we want to give that medication in a less side effect form. So that's why inhaled corticosteroids are the best drug or the drug of choice or the treatment of choice for asthma. Always remember. But our theory won't work with the patient. Patient want relief. So we always add a bronchodilator also. So what is the treatment of asthma? An anti-inflammatory plus a bronchodilator. So we have two group of drugs called controller drugs and reliever drugs. Controller drug is for what? Controlling the airway inflammation. reliever drug is for the relief of the symptom or bronchospasm. Got it? So, what are the examples of controller drugs? Corticosteroids and leukotriene antagonists. Monty Lucas, the medicines you have heard of. And what are the reliever drugs? Beta 2 agonist, example, salbutamol, salmeterol, formoterol. Leukotriene modifiers also can be a reliever drug also. And there is the theophylline, etc. But the drug of choice for bronchospasm is inhaled bronchodilator, that is inhaled beta agonist, that is salbutamol, salmeterol, formoterol, etc. Okay, so that is a treatment. So we have examples of inhaled steroids. Examples, suppose the examiner asks, can you mention few inhaled steroids or inhaled control drug? It is budesonide, fluticasone, mometasone, betamethasone. These budesonide and fluticasone are very popular now, very freely available. You must have seen now patients carrying inhalers contain inhaled steroids. Examples, budesonide, fluticasone. Mometasone and betamethasone are also used, but not very frequently. So the reliever drugs are salbutamol, formoterol, and salmeterol and salbutamol also. Okay. So to stress again, the best or the drug of choice for asthma is inhaled steroid. Why is the drug of choice? Because we want, if you control the airway inflammation, the bronchospasm automatically will be controlled. So this is the best treatment for asthma. You give inhaled medication which contain inhaled steroid plus a bronchodilator, preferably with a spacer. This is a spacer and this is a inhaler. But the most unfortunate thing here is, if you don't teach the patient very well how to use an inhaler, this medicine is useless. I think that's the most important thing. You have to teach how to do the inhaler. I am not going to the steps of inhalers, which is also very important. If you ask me what is a perfect inhaler, what is a perfect inhaler? This is a perfect inhaler. No teaching is here. Very good inhaler. If you give the inhaler, everything will go out. No smoke will go out if the person take a cigarette. So this is a perfect inhaler. So what is a perfect inhaler? The thing has to be small particle size and I will skip that. But inhaler, there are inhalers available for 400 rupees to 2000 rupees. Different companies making different devices. I can say there is a device war. Companies are coming with it. When you prescribe an inhaler, who is important? Patient. Very good. Patient is very important. Unless the patient don't use it, it's a waste. So you have to, if the patient doesn't like the inhaler device, it's a useless business. So you have to select the inhaler based on the patient education, patient's knowledge, patient affordability. Otherwise, the patient will not continue, and that is also very important. What is this? Sir was telling he will use Tamil in between. I have a habit of using these figures in between. Sometimes this is a 2 rupees polythene cover. He is using as a swimming suit. See, rather than buying 500 rupees or 1000 rupees swimming suit, how intelligently he is doing this one. 2 holes there and very efficiently. So this is the point of inhalers. You have to find out a cheap, effective device. Now, Amitabh Bachchan is a very heavy asthmatic. He is using an inhaler costing 2,500 rupees per this. He can afford that. I cannot prescribe a poor man of that mission. So I have to look into that economicity, and selecting inhalers is also very important. But along with inhalers, avoiding the risk factors, trigger factors is also very important. Now, these pet animals are very triggering factor for asthma. Mother smoking and other pet animals and this environmental smoke, everything has to be addressed. Giving inhalers alone is not very this thing unless you are testing. I think with that. So if I ask who can control asthma, this is our one of the current treatment going on. And if you do change this into our inhaler treatment, I think from 11% to 80% or 60%, you can do treatment wonders in asthma management. But we require the celebrities support also. No? Priyanka Chopra is an asthmatic. She came boldly into the media that he said that I am an asthmatic. I have been using this inhaler from the age of 5. You won't believe after this advertisement, people started using in North India to a great extent. Because that's the impact of celebrities. No? When Mohanlal says something or Vijay says something, we accept rather than Jayaprakash speaking on inhalers. So with that, we will this stage. So I will take the key points of asthma. It's a chronic inflammatory disease. Spirometry is the test for diagnosis. Understood? Inhaled steroids are the best drug. A combination of inhaled steroid and bronchodilator is the ideal combination. And the aim of treatment of asthma is to get control of this asthma. And inhaler device and technique is very important. Health education, avoiding trigger factors, pollutions is also, pollens, allergies also very important. I hope that you got an overall idea of asthma now. Okay. Now we will go to the second topic. Seriously, whenever there is time, you can just tell. Because, when I can finish. Now we will go to the second topic, COPD. What is COPD? Chronic obstructive. What is the other name? Chronic obstructive airway disease. So COAD. It's also same. Okay. Sometimes it will happen now. In last week our MD examination happened in Kerala. One question was Moraxella catarrhs. Instead of that, they asked Brahmahella catarrhs. My postgrad student didn't write. But actually, that was a synonym of Moraxella. Moraxella catarrhs, they know everything, writing a page full. When that synonym was asked, they could not write. So sometimes your question can be COAD also. No? So what is COPD? It's chronic obstructive pulmonary disease. Basically, there are two diseases in that. One is chronic bronchitis, other one is okay. Some books may there is one more small airway disease as the starting of COPD. So COPD basically has small airway disease, chronic bronchitis, emphysema, but these are the clinically manifesting diseases. What is chronic bronchitis? They will come with cough. Emphysema patient will come with breathlessness because of the hyperinflation. Okay. This is the definition, bit boring. COPD is a heterogeneous lung condition characterized by chronic respiratory symptoms like breathlessness, cough, sputum production, and there can be exacerbations in between. So that's the definition. And when there is abnormality in the airway or abnormality in the alveoli, predominantly when the airway is involved, the patient will have a chronic bronchitis variant. When the alveoli is involved, hyperinflate, you have emphysema changes. When smoking starts, who develop chronic bronchitis or who develop emphysema or both will depend upon the genetic predominance. You cannot predict. Some may develop emphysema more, it's a genetically determined. Okay, so why COPD is important? I think this is important because it is a third leading cause of death in the world. See, the number 3 cause of death in the world is COPD, chronic obstructive pulmonary disease, not our tuberculosis, COPD. So this is to be, we have to learn more about this disease. Okay, and COPD patients are 5-fold likely to develop cardiovascular disease. So when the lung is affected, the heart is subsequently affected. So normally we have risk of cardiovascular accidents. Now when there is COPD, there is 5 times increase the chance of cardiovascular disease. See, same as asthma, the prevalence of COPD is also very high. It is almost 7 to 11%. India also we have nearly 11% as the prevalence of COPD. It's not a small number. So now what are the causes of COPD? We know COPD is chronic obstructive pulmonary disease. There are 2 types, chronic bronchitis, emphysema. And what are the causes? Now way back when I was doing my post-graduation, there is a book called Crompton's Textbook of Respiratory Disease, like your Davidson. This Crompton came to Trivandrum and for a lecture. He said there are 4 causes for smoking. Number 1 is 4 causes for COPD. Number 1 is smoking, number 2 is smoking, number 3 is smoking, number 4 is smoking. What he want to convey is that is the commonest cause of smoking. I mean COPD. Even though we have other factors like biofuel exposure, we have environmental pollution, occupational exposure like a bad job, like people in the tarring work and road tarring, etc., etc. Asthma, when you poorly manage, gradually develop into COPD. You know that asthma patients, when the years go on, which is poorly managed, will change on to asthma. Now it is said that the fourth common cause of COPD is asthma. Number 1 is smoking. Number 2 is biofuel exposure. No, cooking this, firewood, everything. No. So the causes or predisposing factors for COPD are cigarette smoking, biofuel, environmental pollution, the patient's occupational exposure, asthma, and recurrent respiratory infection. Suppose I have a bad immunity, getting recurrent respiratory infection, that is also cause COPD. But always remember, all smokers or all those who are exposed to biofuel will not develop COPD. Only it is genetically determined. If 100 people smoke, only 25 to 30 will develop COPD because of the genetic predominance. But you cannot allow smoking now thinking that it will not develop COPD because cigarette has a lot of other effects including lung cancer. Okay, lung cancer. So these are the causes, and this is the number 1 cause for smoking and COPD. And it is said that 70 to 90% of COPD is caused by smoking. 25% of the smokers will develop COPD, genetically determined, and there is some genetic component for developing this COPD. See, one of the patient who was in the ward admitted with COPD, when the security lady, when there, how cleverly he is hiding the cigarette and BD there. Inside the bread, he made a hole and he put the cigarette and BD. That is the affection to smoking. That's the addiction to smoking. So you have to do hectic work to prevent that smoking. No? So again, stressing the etiology of smoking in COPD or smoking. This is the firewood or the biofuel exposure. You can see the heavy smoke which is in the this is actually the North Indian scenario. This is a picture from Bihar, and lot of smoke with poor ventilation. Even our habit of cooking at rice or something like with our firewood, lot of smoke are being exposed to female. And there is a landmark study which is published a couple of years back saying that in India, the commonest cause of COPD in females is not smoking. And the commonest cause of COPD in non-smokers in India is biofuel. But it's gradually changing into our cooking gas, probably the prevalence will reduce. So how does this tobacco smoke or pollution or whatever it will produce? This we call as the noxious agent or the culprit agent. Gradually, the genetic factors and respiratory infection, other factors also will come, and the patient will have damages in the lung, and COPD is developed. Simple pathogenesis. But the pathological changes happening in the lung due to chronic smoking or chronic pollution or recurrent infection, what are the changes which are happening in the lung? I think this you need to understand. There is a chronic inflammation happening in the lung. And what is the difference between the inflammation in asthma and COPD? It is neutrophilic. It is eosinophilic in asthma, it is neutrophilic in COPD. There comes the difference in the management also. Our inhaled steroids will not work in COPD because it is neutrophilic inflammation. And there are a lot of mucus secretion happening in the lung. The airflow will be obstructed or limited, we call it as airflow limitation. Since the airflow is limiting, because of the mucus secretion, everything, what will happen? Air will trap in the lung as days go on, and the lung will hyperinflate, leading to emphysema. And there will be subsequent to hyperinflation and what will happen? The oxygen carbon dioxide exchange will be impaired, so the gas exchange will happen. Finally, the patient will have emphysema, subsequently the heart will involve, the patient will develop pulmonary hypertension, and have you heard the terminology core pulmonary? So all the complications will be developed. So this is chronic bronchitis and emphysema variant. Now the big question, when you suspect COPD in a patient? When will you suspect? Simple. Any adult more than 40-45 years. Asthma is you suspect even in 1-year-old child or 90-year-old man. But don't suspect COPD in a 5-year-old child, because it requires a continuous exposure of smoke or other factors. So usually COPD occurs in adult more than 40-45 years, and the symptoms will be adult with the smoking or other exposure factors coming with cough, chest, sputum production, etc. Symptoms you suspect COPD. So when you suspect COPD in an adult who has a risk factor exposure, especially smoking, coming with any of the respiratory symptoms, maybe cough, maybe chest pain, maybe breathlessness, just suspect COPD as a possibility. Okay, but the common symptoms will be cough with expectoration and breathlessness. Suspect COPD and do a clinical examination. Sometimes you will get crepitations, sometimes you will get bronchi and hyperinflation. Okay, emphysematous changes, hyperinflation, and you confirm the diagnosis with what? So this is a typical COPD patient. Typical. Usually above age of 40-45 years. He will be invariably a smoker or a risk factor exposure. He will complain of cough or exertional breathlessness, and the lungs will be hyperinflated like this, and you may get bilateral bronchi. Bilateral bronchi. That's a typical COPD patient with emphysema. If the patient is chronic bronchitis, this hyperinflation may not be there, but there can be associated complications of chronic bronchitis. Okay, but pure COPD, pure emphysematous and pure chronic bronchitis variants are rare. Most of the cases you have combination of both chronic bronchitis and emphysema. Sorry. So again, the confirmatory test like asthma is a spirometry. You can do the spirometry, and the hallmark is both asthma and COPD will show airway obstruction. And asthma it will be reversible. In COPD it will be irreversible or poorly reversible. What is the reversibility? 12% at 200 ml. If it is not there, some days there will be only 12%. That 200 ml may not be there. Some days there will be 10%. All these will suggest there is a poor reversibility. Then you have to suspect COPD. So just understand a spirometry showing airway obstruction with the poor reversibility is the hallmark of suspecting diagnosing COPD. And how to treat COPD? Asthma treatment we know it's because of a inhaled steroids and a bronchodilator combination. COPD treatment is little difficult as this disease slide shows. For treatment purpose, we divided the COPD patient into 3 groups: Group A, Group B, and Group E. Like Congress Party in Kerala has 20 groups, Kerala Congress has 20, like that. COPD groups also we are dividing into A, B, and E. Need not worry about that. Just concentrate on this. This is the treatment. For COPD patient, the airway inflammation is neutrophilic. To control neutrophil, you have to give antibiotics. So we cannot give antibiotic for a long period. So we are just keeping the symptomatic relief for COPD patients. The symptomatic relief is with bronchodilators. So what is the drug of choice for COPD? It is bronchodilators. Why bronchodilators? If I want to give a hit to her, I am alone is enough. If I want to give him, I need to carry one more my friend to do that. Because it's an irreversible bronchospasm, you require a combination of bronchodilators. So we call it as bronchodilators are the choice. So what are the bronchodilators we have? Long-acting beta agonists. We have another group of bronchodilators called muscarinic agents, anticholinergics. So a combination of beta agonist and a combination of beta agonist and anticholinergic or muscarinic agents. We call this LAMA. What is LAMA? Long-acting beta agonist. What is LAMA? So what is the best treatment for COPD? Bronchodilators. To be more specific, beta agonist plus anticholinergics. To be more specific, long-acting beta agonist plus long-acting muscarinic. To be more specific, LAMA. So that is a treatment. Got it? So that is a treatment. And you can add inhaled steroid in COPD in these situations only. What are they? When they have multiple hospitalization. A COPD patient admitting 5 times or 3-4 times in every year. That patient you can give little inhaled steroid, there may be a improvement. Or when there is a blood containing is high amount of eosinophil. When my blood has more eosinophil, it is logical to think that my airways also have some eosinophils. So inhaled steroid will be useful. Or a history of asthma also. A COPD patient, 45 years or 50 years coming to you, are you smoking? Smoking. Do you have exertional dyspnea? Yes. So COPD is a diagnosis. But he will tell you that at 5 years to 8 years I was asthmatic also. So that group of patients, when there is a history of asthma also, you can add inhaled steroids. So when will you add inhaled steroids? Even though we know the best treatment is LAMA, when the patient is an associated asthma, when there is high eosinophil count, or when there is more number of exacerbation, you are permitted to use inhaled steroids. That point of time, what is the treatment for COPD? LAMA plus inhaled steroids. That's called ICS, inhaled steroids. So LAMA plus ICS is the best treatment for COPD in that particular. So again, an inhaler with a spacer is the best one because patients with COPD has a less healthy lung or less powerful lung. So taking inhaler will be difficult. So the spacer will help them to take it correctly. Okay. But always remember, you are treating a disease which is poorly reversible. You are treating a disease which is irreversible, unlike asthma. So what you have to do is, you have to give pulmonary rehabilitation or exercise. When the COPD is very high and oxygen is deficient, you can give oxygen therapy as a treatment. You can give lung transplantation if the COPD is very severe, but we rarely do that. And what is very important is, since a COPD patient, you have to remember that asthma, once the airway inflammation is addressed with inhaled steroid, they have a normal lungs. COPD is already damaged lung. What is the most important lung function other than respiration? Why we are living after COVID? We all had a good defense mechanism. Even though we go to a BC patients with tuberculosis, why we are not developing TB? Because our lung has a defense mechanism. So pulmonary defense is the most important non-respiratory function of lung. Most important function is respiration. But lung has other functions also. But in COPD, what will happen? The pulmonary defense will be lost. So he will be prone for infections. When infection, he will be in the hospital for admission with pneumonia. So we can do vaccination, especially with influenza, that's a virus, which is very common nowadays, and pneumococcal vaccine, because Streptococcus pneumoniae is the commonest bacteria which produces infection. So vaccinate, do some exercise, rehabilitation, and oxygen therapy, etc. But don't forget to prevent or avoid is smoking. Without that, there is no point in treating the patient. So the most important step to prevent smoke in COPD is preventing smoking is one. You try to avoid start smoking. For that, you have to start from the school level itself. If you start the teaching of avoid smoking from the school level, the prevalence of COPD I will swear it will come to nearly half. No, starting with smoking, it's easy to prevent smoking. So the best method is to prevent cigarette smoking. So we'll take 5 minutes for the tuberculosis, which is a third common disease. Who is this? This man in 1824 said that I have discovered a bacilli called tuberculous bacilli, which is going to destroy the humankind, which is going to destroy the mankind. And in even meeting of physicians, he came, he is a microbiologist. He said that I have found out an organism that is going to kill the mankind. And we all are here. COVID came, we all are here. So that is because of the development of drugs which were actually produced. So this man, who is this man? Nobody knows? He has a vision, whatever he is, plus or minus point. India has the highest prevalence of tuberculosis. We want to eliminate TB by 2025. As a pulmonologist, I will say, even in 2035, sir also will agree, we will not eliminate. We cannot, because 27% of the global TB is not in Africa, not in China, in India. Out of 100 TB in the world, in the globe, 27% is in India. America may vanish tuberculosis, we cannot. But we will definitely reduce the prevalence of tuberculosis. He had a vision that we should concentrate more on. And because of that, our TB program is now what? National TB Elimination Program. We were concentrating on a National TB Control Program. But because of his vision, we actually we are trying to eliminate the TB program. Whether we succeed or not. Now, what are the key points of tuberculosis? Tuberculosis is caused by mycobacterial tuberculosis. 27% of the global TB is in India. That is the prevalence. Now we are heading towards eliminating TB, so that the program has changed into National TB Elimination Program. Another program which we are facing globally and now in India is multi-drug resistant tuberculosis. The most common cause of drug resistant tuberculosis is what? Irregular TB taking the medicine or incomplete TB taking. He had a patient fibrosis, but she had 6 months of complete ATT. So irregular incomplete TB is the best. Is the most common cause for India. So how you make a diagnosis of tuberculosis? We have to demonstrate that organism. Simple. You have to demonstrate that organism. Even though patient will have a cough of 2 weeks or fever of 2 weeks, you take an X-ray, you make a diagnosis. But finally, the confirmatory test is to demonstrate the acid-fast bacilli. The methods are our old seal-Nielsen staining, which we studied in the microbiology. Now the test which we are using commonly is called a nucleic acid amplification test. That is a test which we are doing. We have 2 tests called CB-NAT and TrueNAT. That I will come in the next slide. But AFB culture or a bacilli culture also is equally important. So what is the gold standard for diagnosis of tuberculosis? Demonstrating AFB bacilli or culturing tuberculosis bacilli. That is the gold standard. So the question I asked in the morning, when will you suspect tuberculosis? Anyone who has cough and fever more than 2 weeks, anyone who has a virus of unknown origin, anyone who has loss of appetite, loss of weight or blood in sputum, or anyone have extrapulmonary like a lymph node here or a bone pain, you have to suspect tuberculosis as the cause. The common thing to suspect pulmonary tuberculosis is cough and or fever more than 2 weeks. Okay, is that right? This is our traditional method of diagnosis. Okay, you take an X-ray and the X-ray will show a finding like a cavity here suggestive of tuberculosis, or you demonstrate bacilli through the microscope. Okay, our seal-Nielsen technique. But this is now shifted because in the elimination program to eliminate TB. Another thing by which you can make diagnosis, if there is a patient with a lymph node tuberculosis, what will you do? You do a biopsy and FSC demonstrating what? Non-caseating granuloma. This is a granuloma. This is not caseation. This is necrosis. So caseating necrosis is the hallmark of tuberculosis. Okay. Non-caseating is the hallmark of other disease. Caseating granuloma is the hallmark of tuberculosis by biopsy. So caseating granuloma is the hallmark of tuberculosis. This was our conventional culture media. What is that media called? Media. Still being used, but it will take a long time for the bacilli to grow. So we are using a test called line probe assay or MGIT. What is MGIT? Mycobacterium growth indicator 2. When the bacilli grow, the blue light will come. With that we can say there is none. So there is lot of being in this. You just open when there is a blue light or green light, there is a growth. Number 10, there is a growth, so it's a positive. So that's the beauty of this. You can load 960 specimens in a single time, and it will take a very quick result also in 2-3 weeks. So that's the this will take a lot of time, including our power failure. I think the result is going to be bad. So culture, we have a MG80 lightning probe assay. For our conventional staining, what is the substitute now? CBNAT. Now we are familiar because we were using this in doing COVID time. The same test for. So we have a machine, we have cartridge like our printer, our computer printer. You take this cartridge, load that sputum there, put it, and you will get the result in 2 hours. 2 hours you will get. That's the beauty of CBNAT. But what is the problem of this CBNAT? CBNAT, this cartridge is very costly. US people are not allowing to make any other country this one. So India cannot make. China may make, but they are also failed. And this is costing nearly $100. Very huge amount. So what we did was, we made our own indigenous nat. That's called true nat. So CBNAT or true nat saying, what is the difference? CBNAT is cartridge based. True nat is chip based. See the chip. You can load a sputum here, put it, and you will get the result. Both are equally good. So we are India using true nat as the common method, but selected cases, being CBNAT a bit costly, we are using for selected cases. So our conventional microscopy now is changed into CBNAT and true nat. In one word, it is nat test. India are using true nat, and the only difference is it's a indigenously made chip based test. So the treatment of tuberculosis also changed from revised national TB program into our national TB program. And what is the treatment? Most of the cases, 6 months treatment with 2 months of 4 drugs. That's called the intensive phase, intensive treatment, and 4 months of continuation phase. In the first 2 months, you give 4 drugs: INH, ethambutol, rifampicin, and pyrazimide. In the continuation phase of 4 months, you give INH, rifampicin, and ethambutol. Pyrazimide is actually omitted. Now we are giving tablets which contain, each tablet contain all the drugs. When I was student, we are giving INH, rifampicin separately. So I have seen patients who have kept all the rifampicin under the pillow, and only the other drugs are taken. So the most effective drug is being, because rifampicin will produce little nausea. So he will get that. Now the patient cannot do that because we are giving a drug called fixed drug combination, and the number is according to the weight band. 435, 3, like that. It's very simple. So we cannot take away one. So that is a change which happened in the recent treatment. Okay, I think with that we complete. There are post-tubercular complications like post-TB, fibrosis, cavity. All these are also chronic respiratory diseases. Like our case which we discussed, that patient also is going to have respiratory problems because. So post-TB sequelae are also, if you are asked to write a short note on chronic respiratory disease, post-TB sequelae also you can do. These are the sequelae which are coming. Now we will have the 5 more minutes. Suppurative lung disease. What are the 3 suppurative lung diseases you know? Bronchitis and abscess of emphysema. And I will complete in one slide each of all the diseases. What is bronchitis? It's a permanent abnormal dilatation of the bronchus. Due to what? Due to the destruction of the muscular and elastic component of the bronchial wall. Okay, bronchus is not dilating just like this. It is dilating due to the destruction of the elastic and muscular component of the bronchial walls. So you can expect the bronchus is damaged. So what will happen? The lung defense mechanism will go. So the patient will come with recurrent respiratory infection, cough, recurrent sputum production, and blended sputum. And chest X-ray may show cystic shadows because of the dilated bronchus. And the best test or the confirmatory test or gold standard, Sarah was telling in the morning, each diagnosis, each disease has a gold standard. So the gold standard test for bronchitis is not CT test, high resolution CT test. high resolution CT test. And the treatment is, whenever he comes with infection, you have to give antibiotics. And the permanent treatment is surgery, because the bronchitis is not revertible. But if it is localized to one area, you can do surgery. But if it is diffuse, you cannot do. So that is about bronchitis. And this is the radiology of bronchitis. Can you see this is a normal lung? Can you see a lot of cystic shadows there? Lot of cystic shadows. These are all bronchitic area. In the higher resolution CT, this will be the picture. This is a normal lung. This is a normal lung. This is all cystic, thick-walled, cavity-like things. Actually, that is bronchitic area. So X-ray showing cystic shadows. This is the pathology picture, and this is the radiology picture. So lung abscess already discussed. It's a localized collection of pus. The patient will be having purulent sputum with sometimes foul spelling, and the treatment is antibiotic and postal drainage. Sarah has also showed two-three picture. It's a localized collection of pus. That is lung abscess. Empyema is actually collection of pus in the pleural cavity. When it collects the lung, it is lung abscess. When collecting the pleural cavity, is empyema. So when it is a lung, the patient will have foul swelling, purulent sputum. When it is in the pleura, nothing will come out. The patient will complain of chest pain, cough, fever, etc. And you take an X-ray. This will be the picture. Now the previous one, there was abscess here. There is a collection because of the pus collection. What we do is, whenever I have a suspicion of, what is the clinical suspicion of empyema? The findings will be same as pleural effusion, but you will get a tetanus, fever, suspecting empyema because pus. What I do is, I put a needle. If pus is coming, I stop there. I put a chest tube, because some fluid you can let in the chest, but pus you cannot. The patient go for sepsis, fever will not come down. So if it is pus, immediately I put a chest tube or ICD and give antibiotics formally accordingly. So that is a treatment. So I read about lung cancer. So lung cancer is the most common cancer nowadays. It is the most common cancer in males. So two questions. What is the most common cancer in? There is some data confusion, but WHO says lung cancer is the most common cancer among cancers. And males, the most common cancer is lung cancer. There are two types of lung cancers. One is non-small cell, the other one is small cell. Small cell, there is only one subtype. In non-small cell, we have squamous cell carcinoma and adenocarcinoma and large cell carcinoma are the subtypes. So we have non-small cell and small cell carcinoma. Non-small cell, there are three types: adeno, squamous, and large cell carcinoma. And world over, when I was student, and Suresh sir also will agree, squamous cell carcinoma was the commonest. But now the data is showing adenocarcinoma is the commonest lung cancer due to different reasons. So again an MCQ, what is the commonest lung cancer worldwide? The prevalence in India says it is adenocarcinoma. Okay. So the risk factors are cigarette smoking, air pollution, heavy metals like radon, nickel, chromium, asbestos exposure also. If you expose to asbestos for 20 years, and COPD patient, pulmonary fibrosis or chronic lung disease, the defense mechanism is gone, so that also will lead on to carcinoma lung. And there should be a genetic predisposition also for that. Okay. And this is the radiology. The typical patient will be usually aged man, a chronic smoker. The symptoms will be cough or bleeding sputum or chest pain. On examination, there will be clubbing. X-ray or CT showed a typical mass lesion. But always remember, malignancy can manifest in different way. I have seen patients presenting as pleural effusion as the etiology of malignancy. I have seen patients presenting as consolidation as finally came as malignancy. But the typical one is a mass lesion. And the diagnosis by X-ray, CT scan, bronchoscopy. Finally, you have required biopsy for confirmation. And before treatment, you stage what is the staging, and then you send to the radiotherapy department for management. Early stages, you may do surgery. Later stages, you may do palliative therapy. In between, chemotherapy, radiotherapy, or combination of both. So that's the treatment. Last one is an interstitial lung disease. Only one slide I want to show. You have an interstitial. This is your normal alveoli. This is your blood vessel in the lung. And the space between the alveolus and the blood vessel is called interstitial. Okay. This normal shape of the lung is given by the interstitial, not by the airways, not by the alveolus. So that is a supporting tissue of lung. So the lung here is getting the shape or the supporting tissue of lung is the interstitial. This is a space between your alveolar and blood vessel. When that area gets diseased, we call it as interstitial lung disease. And this is a normal lung, and this is a interstitial disease lung. Okay. So this is a normal CT chest, and this is a interstitial lung disease. See how bad is the lung? Huh? So it's one of the bad. I would say advanced likelihood is worse than malignancy. No doubt. My cancer patients are living for some 2-3 years. But ILD like this, its prognosis is worse than malignancy. But early stage we can do. So what is a test to confirm? A high resolution CT is the one which gives this picture. This is a normal lung. This is a. So HRCT will help you to make a diagnosis in 80% of the cases. Very rarely I do a lung biopsy. We suggest a lung biopsy to confirm. And the treatment is 3 treatments. Sometimes we give steroids. Sometimes you give immunosuppressants. Sometimes selected cases you give antifibrotic. Because interstitial lung disease, the most common complication is fibrosis development. To prevent the progression of fibrosis, you give antifibrotic. So I think I am sure that I made you some boring this thing, but one hour has passed. So I think you could follow some chronic lung disease. What is the most common lung cancer nowadays? What is the pathology of asthma? Eosinophilic inflammation. What is the best treatment for COPD? What is the best test for diagnosis of bronchitis? I think I will agree with Suresh sir. These students are smart.
Thank you.